Hi, I'm Dr. Malaraj, Endoscopic Surgeon and Managing Council Member of IAGE. So it gives me immense pleasure to welcome you all to the third episode of the IAGE Podcast series, The Master Speaks. So the master for today's podcast series is Dr. Sanjay Patel. Dr. Sanjay Patel sir is a very renowned endoscopic surgeon, and also he has specialized very well in endometriosis surgery. So today we have the pleasure of having sir with us, and he has lots of accolades to his credit. So in fact he started laparoscopic surgery way back in 1997 and has been doing pioneering work ever since then. So he has got the maximum number of papers on tubal microsurgery and also in adenomyosis surgery. So apart from that, he is the first one to perform the laparoscopic Wertham's hysterectomy in Asia, and also has been the first to do the laparoscopic bowel resection and anastomosis in endometriosis. Apart from that, he also has various accolades like training almost more than 2000 gynecologists in laparoscopic and advanced surgeries, and also has conducted various workshops and also multiple conferences, and has been the key orator in various conferences. Apart from that, he has also got multiple awards. The most one among them would be the Escolab Golden and the Platinum Award. So we have the pleasure and honor of having Dr. Sanjay Patel sir with us, and in fact it is our honor to welcome Dr. Sanjay Patel sir to this podcast series. So in fact, in a nutshell, if you say, I can tell that Dr. Sanjay Patel sir is a encyclopedia in endometriosis. That is the amount of knowledge and skill he has in endometriosis. So welcome to our podcast series, sir.
Thank you, Mala, to take so much pain to coming from the very far away Chennai to the Ahmedabad for this podcast. Thank you very much again.
It's our pleasure, sir. So to start with, I would like to know, how was your journey? So how did you really start your laparoscopic adventure, in fact, and how did you reach to this pinnacle in your life?
Actually, Mala, what's happened, I am not much more key interested for the obstetric. So once I pass my MD, I leave these professions. And couple of months I am at Diamond Market, Pancharatna Diamond Market at Mumbai. And after a couple of months, my father is ringing me. I read one article related to keyhole surgery. And if you don't want to do the obstetric, better you choose this subject. And then I pick up this keyhole surgery. This is the new era, new throats. Even though I couldn't know the future of the keyhole surgery, but I think today era, entire globe with this laparoscopic surgery.
So what exactly the kind of keyhole surgeries you did during those days, sir?
Actually, I flashback related to my story. Once I passed MD from the Cancer Institute, at that time MS degree is not there with the gynecology. It's the MD Gynec. So I passed from the MPSA Cancer Institutes, and I feel that at that time, I think my associate professor, late Dr. Meeta Makad, and my professor, Dr. K.S. Dave, is telling me, Sanjay, we have the vacant post for the fellowship program, for the particular for the 1 year fellowship program in MPSA Cancer Institute. Better you join it. I spoke with my teacher, Dr. Meeta Makad. I don't want to join it because at that time the Wertham's is very long surgery and it's only done with the professor and associate professor. And my job to only take the doers retractor and retract the abdomen, nothing else. And meanwhile, if I get the opportunity, I look for the ureter, bladder, and retroperitoneal anatomy. So I spoke with my teacher. I don't want to continue with this fellowship program. If I continue with the same professors, within 6 months, I performed the radical hysterectomy. I took the photographs, I do the lymphadenectomy, and I sent to the EU. And only one center at that time for the radiotherapy in Gujarat is the Cancer Institutes. So again I go back to Mehsana. I started my career at Lions Hospital. This is the one of the charitable trust, and it's near to the Rajasthan because Rajasthan is the one of the pocket having the lot of CA cervix cases. So after 6 months later, I sent the one case with the photograph, with the lymphadenectomy photographs, specimen photographs, parametrium, and I also spoke with the madam. So I accepted this challenge with my teacher. Within 6 months, I performed the open radical hysterectomy, and I do it. So I think this is the one of the game changer for my life. Later on in 1997, I performed the laparoscopically, because in this era, no one can know that related to radical approach for the surgery. And 97, I removed the specimen. 98, 23rd April, I performed with the specimen and lymphadenectomy done with the laparoscopically. At that time, single chips camera, only the monopolar and bipolar energy sources is available. So I couldn't know. I am the first in the Asia to perform the radical hysterectomy, and I am the third in the world after Posever and Bhatti. I am the third person to perform the laparoscopic radical hysterectomy. So this is the one of the game changer for me to establish. But what's happened actually? I do the before 97, I performed so many open radical hysterectomy, and then I performed laparoscopically. If you do the 10 cases of the radical hysterectomy, you get the fluid rhythm, and there is no, I think, endorphin secretion in my life, because it's like the mathematics ABCD, and it's a monotonous work for me. Another game changing is happened related to tubal microsurgery, because before 2000s, I think this is not the era of ART, and ART success rate is not good. So everybody is focused for the tubal microsurgery, and tubal factor is the one of the main cause for the fertility part. So what's happened actually? I pass MD. I apply for the tubal microsurgery training at PS Hospital. One of the iconic persons, I couldn't disclose the name. One of the iconic persons is started the training program at VS Hospital. After 6 months later on, I spoke with the sir. Yes, sir, I applied for this tubal microsurgery training. Please, he told me, better you come at my clinic, and at start 3 o'clock. So I traveled from the Mehsana to the Ahmedabad, and I am in the OPD hall at start 2:45. And sir is coming at approximately 3 o'clock. And after 2 hours later, when I spoke with the secretary of the sir, I need only 2 or 3 minutes just to convey this message to the sir. She told me, please wait. She communicate with the sir and then give me answer. Again, after 2 hours later on, again she is telling me, please wait. So at the end of 8:45, sir is finished the entire OPD, and just he is behind to the chair and putting the journals and books on the wardrobe, and he is telling, why you came here? Because, sir, I applied for this microsurgery training, and it's 6 months is happened. He told that better you wait for another 6 months, and then again you communicate with me. Once I leave, this 6 hours is changing game for my life. Because at that time he is very popular in the entire India related to tubal microsurgery. At the same night, I meet to another my teacher, late Dr. Narayan Patel, and I discuss related to entire scenario. Sir is telling, he never give the Guju people training.
Okay.
Because it create the competitions for him. He always prefer to give the outside of the Gujarat people to give the training. And this is the inspiration for me to start the training program in my life. And also he told that in the next month I am traveling to the Mumbai, and I bring to the open microsurgical instrument for me. At that time the cost is 6,000 rupees, and this is the company of the Kalarkar company. He bring with me. I work for the more than 200 hours on the placenta with the 70 Crowley, and then I applied the same thoughts on the laparoscopically. So in 1994, I performed the tubal laparoscopic tubal microsurgery with the single chips camera with the 7O Proli. So at that time, I think another two people is helping me, Dr. Ajit Rawal and Dr. Sapna Sir, to guided me, because these both are master in the tubal microsurgery, and I think he tried to make the thought how you take the stitch with the laparoscopy with the 6 o'clock stitch, 12 o'clock stitch, 3 o'clock and 9 o'clock stitch. And always these people is guided me better try to make the 2 layer suturing rather than the single layer suturing, because try to make the avoid the kinking of the tube, and this is the principle of the tubal microsurgery. So another one point is happen the western part of the particularly in the Gujarat, the earthquake is happen, and in this year lot of requests I received related to tubal microsurgery, because those who lost the child. In this year I performed more than 200 tubal microsurgery. So I think gradually after the 1995 people is know my name in Gujarat for the tubal microsurgery laparoscopically. But I decided, so my name is affiliated with the tubal surgery. This is the only way, rather than the open surgery, I choose the different pathway, and that's why I started the laparoscopic tubal microsurgery. Might be I couldn't know related, I am the first in the world, or Charles Coe is the first in the world related to tubal microsurgery, because I couldn't publish my work. I couldn't documented my work at the time related to tubal microsurgery. Another one incident I think happened in the 2005. I think this is the ISG event at the Hotel Renaissance and relay from the Hiranandani Hospital. And last moment, Charles Coe is refused to attend this event, and Dr. Prasad Mangeskar is give the opportunity to me to perform the tubal microsurgery. And within 1 hour and 10 minutes, I performed both the side tube with the 70 Proli, and people is appreciate anything in this moment. And at that time, I think more than 2,000 delegates, among that the 400 faculty and overseas delegate. So I think it gives the international name and fame for the me, particularly for the tubal microsurgery. But also I presented my tubal work in the IAGE event, and people is appreciate. I innovated so many things related to juxtamural, intramural, juxtauterine anastomosis, and also I give the one slogan: there is no place of the uterotubal implantations, rather than interstitial anastomosis is always better. Also I worked related to salpingoscopy, and I think without salpingoscopy in our center we consider to be infertility workup is incomplete. So I think rather than the potency is more important, and it's assessed by the only salpingoscopy. So these two things is give the international popularity for me for the for the tubal microsurgery. And then I received so many international invitations for the presented my work.
Yeah, fantastic.
Meanwhile, what's happened also after couple of number of microsurgery work, I also realized that this is the monotonous. This is like the mathematics 1, 2, 3, 4, 5.
Yeah, so
and I am not much more enjoying with this radical hysterectomy or with the tubal microsurgery. Yes. So I started the different focus to give the endorphin secretions in my life. This is the another things to I switch over toward the endometriosis work. I tell you the story how I started this work, particularly for the endometriosis later on. Before that, another thing will be summary related to my journey and what's happened. Actually,
so basically, we all think that your name is affiliated to endometriosis. You are an endometriosis specialist. All of us, know you as an endometriotic surgeon. But then the fact that your tubal microsurgery has been your really stepping stone, and how you converted yourself from an open surgeon to a laparoscopic surgeon. So that is what I think has really made the difference. So because you had a skill in an open surgery and you are able to translate immediately that into laparoscopic surgery.
Yes.
In the era when we did not have any 3D laparoscopy or of course the robotic, which all that is there right now, which makes the life lot more comfortable. So in the era when you had just a single chip camera, you were able to perform laparoscopic anastomosis recanalization is
with
something.
the 5-0 instrument.
Yeah. So that is really phenomenal, and also that clearly shows, of course, your gynecological, oncological work also. So the most important requirement for any surgeon is they should have the skill of dissection and suturing. Both were there with you. So the dissection was the one which helped you to do the oncological work, and suturing skill helped you to do the recanalizations. So I think that both skills were able to take you forward with many advanced procedures like endometriosis also. So
Cancer
how
is
can I hear?
Cancer is contributed lot of Cancer Institute contributed lot of in my life, because it's give the boldness to the me, and also I know the related to this retroperitoneal
Anatomy. You
anatomy.
were strong with your anatomy.
This is the one thing I think, because I switch over on the for the more advanced work. Before I started this one, I tell you, actually what's happened, my English is little bit poor. Not little bit, it's much more poor.
Language is not a barrier.
So what's happened,
for
actually, I thought that when I built up the Mayflower Institutes, I thought that might be I presented on the better way, so I learned the more English. So I attended one of the English speaking classes, Dipti Sah. It's a very good teacher. She's the great teacher. So I hide my entity myself and I joined this class. This class started at 6 o'clock. At that time, I do the late night work up to the midnight. Sometime I leave my OT at 3:30, 4 o'clock midnight. And also I joined this English speaking classes at 6 o'clock. So always I am late. At that time, there is a one rules. If you are late, put the 10 rupees. Okay. The first day I put the 10, second day I put the 10, third day I put the 100 rupees note. And I told that this is the advance money for the bill. But Dipti Sai is so smart, and she realized that he is the different guy. And after a couple of days later on, she told me, better you come in my chamber after once you finish these classes. मैं जब मैडम की चैम्बर में गया, मैडम is telling me, Dr. Patel, I know everything related to you right now. She inquired me lot of. You couldn't require the English. Another one thing is changed my life, because Chi Long Li is invited me at Taiwan, at Taipei in 2003. And my talk is related to tubal microsurgery. And entire night, I think I'm mumming with my lectures to avoid the grammatical mistake. And what's happened, I couldn't sleep in the entire night. In the morning, once at the 11:30, it's the peak time I deliver my talk. It's approximately 25 minutes. It's a main keyhole talk. So I realized that only the few people, one is the Professor Rudy, from the grandson of the Professor Love and Bellies, Belly and Love. So he's the grandson of the Love, and he delivered the talk in the English. Myself and very few people is delivering the English. Rest of the Japanese people speak in the Japanese language, Chinese people speak in the Chinese language, and Korean people speak in the Korean language. So I realized that language is not the barrier for me.
Yes.
And then I decided to whatever the way you try to make the explain to your training. And I same pursue with my entire life, and people is accepted me, and even though whatever the way I presented, people is learn related to this laparoscopic part.
Correct.
In another one incident is the game changing for me. In 1994, I think Victor Guhilis came. Before I started the open microsurgery, I took the training at Bombay Hospital, because this is the 4 days workshop, and Professor Victor Goyal is the father of open microsurgery. And another Adam Mangos is from the UK. He done the hysteroscopy workshop at Harkison's Hospital. And a couple of days I spent with the M by Rawal Sai for the transvaginal sonography training. So at that time my salary is only 4200 rupees. And this entire 15 or 20 days I spent 49,000 rupees including fee, hotel stay and everything. So it's a huge amount of the money I borrow from the my friends, and it's required 2 years to return back this money. I decided at this moment, in my institute there is a no training free. In today, instead of the we continue fellowship from the 1996 to the today, we give the stipend to the very good amount of the stipend to the all our fellow, and we never charge them the single amount of the money for the any training.
Okay.
So this is the things I learned from this incidents, and we realize that once you pass the MD, we have the lot of responsibility related to family and kids. And if at that time if you take the money from your trainee or your fellow, I think it's not the good part. So this is also one of the things I learned from my experience, and I think still continuous pursue with these same things in my institutes.
Okay, that's really fantastic, sir. And that is a noble deed, in fact, to train your students free of cost is something phenomenal, because you're not only just sharing your skill, you're spending your time with them and teaching them something which is really, I think, because of your experiences, you really wanted to do that for them. But that's really, really fantastic, and it has to be really, I think it's a noble deed, in fact. But how did you move over to endometriosis?
I think this is also very good, interesting story. Before 2000, what's happened? Actually, sonography is not up to the mark, and we look by the transvaginal sonography. So we look for the sliding signs, and one is also we look related to adenoma. We always thought that this is fibroid, and we took this patient for the OT, and we put the incision. We realized that the fibroid is not pop out, and this is adenoma. We suture in it, we close it. What's happened? My very close relatives underwent go for the glioma of surgery in 2000 with the doctor Hinduja Hospital with the Dr. Misra. And this is the 4 centimeter glioma. He just removed at least 40% of the glioma, and he told that, Dr. Sanjay, I think it's near to the very vital organs. So I think just we remove the 40% and we leave the 60%. The BG came to reduce the tension over this tissue. Okay, this concept I grasp it, and I pick up this concept related to adenoma resections. And the next day I came from the Mumbai to the Ahmedabad, Mumbai to the Mehsana, and I started this adenoma work. Previously, I invented so many different technique of if the serosa is involved, then elliptical strip manner. It's a myometrium localized adenoma, then hood technique. If the entire wall is involved, then slice technique. And I realized that after this surgery, not only they improve the fertility part, but it's improved the quality of life. It's reduced the dysmenorrhea. So this is the one of the things. And I realized there is no need to the removal of the entire disease. Just try to reduce the 50%, maximum 50% of the disease. So this concept I pick up from this surgery of the glioma of the brain. Okay. And this is, I realized that if you remove the tension, this is the words I tell you, आप कहाँ से भी टेंशन निकाल दो, यूट्रस में एडिनोमा है, इसको रिड्यूस करो, हाइड्रोसाल्पिंग ट्यूब को निकाल दो. इफ यू रिड्यूस द टेंशन, ऑटोमेटिकली इट्स इंप्रूव द फर्टिलिटी पार्ट. सो दिस इज द वन थिंग आई थिंक we develop it, but at that time I am very premature, and people is not ready to understand my thoughts and concept. In 2003, in Dr. Sadhna Desai event, I presented my work of adenoma resection, is it worth? The title is given on the different way. So I deliver my talk. Suddenly madam is pick up the mic and told to the audience, not me, because Sanjay have the surgical mind, because I know that, and that's why he spoke related to adenoma resections. Otherwise there is no place of the adenoma resections. But I am not disappointed because I know that I have the evidences of the more than 200 cases of the adenoma resections, and I continue with this work. And the next year I presented this work in the IAGE, American Association of Gynec Endoscopy at Las Vegas, in Las Vegas Paris Hotel. So I think my co-chairman and chairman and audience is looking very carefully. These people is not accepted at that time the adenoma resected, but these people is realized that there is just something in this talk. Might be the late Ornella CG and Alfonso from the Italy, very dear friend of mine, and both are started this work. These people choose the Saber Center from the European country, and first time these people is published the 55 cases series.
Okay.
My lacking part, because whatever I do is I not documented, I not publish it. This is one of the lacking part, but I not regret myself. I am very happy. Whatever I am doing, I am enjoying this one. I couldn't know the still today related to computer. I couldn't know the ABCD of the computer, but I hired such kind of the people, those who helping out for the what is my lawful.
Exactly.
What is my backside? I think these people is surplus for the me.
Correct.
So I think I don't like it because I feel that it's never entered into my hard disk. So I never tried it. Those who give the joy and happiness, these things I do in my life. And those who I didn't like it, I never try for it.
Right.
This is my philosophy of the life. And I am very happy with this one. So third important part, I think the first publication came from the European School of Gynec Endoscopy, and this is the message for the audience. This is not only the improve the fertility part, but it's also improve the dysmenorrhea and menorrhagia, and then acknowledged by the Dr. Sanjay Patel technique.
Okay.
Right down by the Ornella CG. So then people started to think for the adenoma resection.
Right.
And believe me, I am the first guy in the world to give the slogan related to there is a role of adenoma resections.
Yes, because prior to that, I think only hysterectomy was the only treatment, or it used to be, if an adenomectomy is done, it used to be like a functional hysterectomy. Almost the entire tissues are being knocked off. I think, yes.
Another one thing, I think the another game changer person in my life is Dr. Haresh Vagasia. I think he worked with me for the 4 years. Then I think he's once he leave from the Mayflower, he joined with the Professor Batoji for the 6 months. 6 months with the Professor Katskine, and also I think 6 months he spent with the Dr. Lika Minali at Verona. I think this is the place right now. Barcelona is continue with this all the training program. So Paula and Lika Minali is the head of the department of the endoscopy. But Haresh is showed my video to the Katska and Lika Milani and even though Batoji. And these people is first time invited me in the European School of Gynec Endoscopy as a teacher. And most probably I am the first Asian to perform the live surgery in the 2007 at Verona. And this is the good gift is given by the Haresh Vagasia as a Guru Dakshina. And I performed the fourth surgery, adenoma resection, to corno-tubal anastomosis, bowel adenolysis and endometriosis, and another one case of the myomectomy I performed it. So this is the, I think I am more popular due to the Haresh, because Haresh is so much attached with the European school, and I think he showed all the video to the entire all training center. So people is no related to me. I think one of the incidents, I think Professor Lilo Mettler is also kept so many video related to my work for the adenoma, endometriosis, tubal microsurgery and radical hysterectomy. So sometimes I think at the time the Kiel University is very popular, and people is watching my video. What's happened, actually I operated the vice president of the Nigeria, and he invited me as a celebrity for the Nigeria to joint collaborations with the training program for the endoscopy. And I visited Nigeria. At that time this entire things will be looked by the MJOR company, one of the best pharmaceutical company from the Nigeria. And I think I visited I forgot the name of this guy and institutes, one of the biggest uh, OBGY institutes in the Lagos. And just I entered in his room, and he's in the shop. He told me, Dr. Patel, you are in the front of me. I couldn't recognize because I couldn't meet him. And he told that I am the one of the fellow at the Kiel University. In 6 months, I am watching so many times your video. So I think this is the things I think gradually people is now related to my work. Second important part, I think endometriosis is the really challenging things. And I think if you looked at 100 cases of the endometriosis, it's the different one. The tissue is different, elasticity is different, texture of the difference, adhesion is different. So it gives the more challenging for me, and it gives the endorphin secretions for me. So in the 2000 onwards, I started to work related to endometriosis. First, we started with the sandwich therapy. First, we performed the surgery. Then we give the Leupride depot. Again, after 4 months, again we do the second laparoscopic surgery for adenolysis. And we realized that what we are doing, it's not right. Because it's so much adhesions, we leave the tissue, we do the adenolysis and we remove the chocolate cyst. So I started this endometriosis journey gradually, and it took the long pathway. I spent my entire 2.5 decades behind to understand the adenoma and endometriosis, but still I feel that I understand the peanuts related to this part.
So endometriosis is constantly evolving. So much of advancement have come in endometriosis. So, but it is such a challenging case. But you were the first one, I believe, to do the bowel resection and anastomosis. But how did you really have the guts to do that? So now, because in those days there were not much of evidences also, like to prove that these things are really going to be helpful for a patient. But then taking the courage to do a procedure at that point of time must have been a real challenge. So how did you get into that?
I think in 2000 onwards, I more pursue with this endometriosis, and I started with because what we are doing, it's not the right approach. So we started to identify the white lesion. At the time, we called the red lesions, black lesion, and white lesion. Whatever we today is told, the DI is the white lesions. And we try to make the identify the hard tissue. And we started, those who suffering from the severe pain, we started to excise this tissue. And then we realized that patient is free from the pain, improve the quality life, and improve the fertility part. So we started more and more work related to excision of the nodules after 2003. At that time, another one story, because what's happened actually during the time of live workshop, if we perform some of the abnormal thing, then organizer is telling me, okay, Dr. Patel, we not take any consent, though don't do it. So it's a lot of people is not ready to accept. I think my thoughts. So in endometriosis, you have to have the excise these nodules, otherwise patient couldn't get any benefits. And whatever we do, the removal of the chocolate cysts and do the adenolysis, it's only the 5% job. 5% job. But I think because this entire responsibility with the organizer, so these people couldn't allow me to cross the boundaries. Sometimes what's happened, even though during the time of surgery, sometimes organizer is telling me, stop Dr. Patel now surgery, and we discontinued and we came out. So this is the incidence. I think it's requires a long time to people is convinced related to this radical approach for the endometriosis. I think in 2007 again we developed this is the one story related to this Mayflower butterfly technique. So we developed entire peritoneectomy in cases of the multiple implant of the. Then we realize that this is the most important part is the rectovaginal plate because it's the main cause for the dyspareunia, and this is the gateway for the colon, gateway for the parametrium. So this is the mathematics we created in the Mayflower butterfly technique. We remove the affected parametrium, we split the nodules, and entire the rectovaginal plate and torus uterus we removed. So this is the game changing also for the me in 2007 to be established, and we work a lot of related to Mayflower butterfly technique. This is the mathematics for the entire heart of this endometrial surgery, and we make this surgery so simple, so it's a replica for the everybody. And now we taught in our SESB courses related to this part. I think you be stuck with this principle. You remove the entire disease, not only the part of the fertility, but you give the better quality of life. In our institutes, rather than the fertility, the main our approach related to give the better quality of life, free from the pain, free from the dyspareunia, free from the menorrhagia, and at the end we give the priority related to fertility. Because I think if you take the detailed history in our center, we took the detailed history. Out of 10 patients, 1 patient have the suffering from the suicidal tendency. So it's very important to understand related to this endometriosis.
True. Very true, sir. This dyspareunia, unless and until we clear the entire lesions in the peritoneum, I don't think so they are going to get any relief. And as you said, very rightly said, sir, the plate, the rectovaginal plate has to be also removed. So unless and until we do that, they are not going to have any relief, because most of the time in infertility, once we do this, most of the patients are able to conceive naturally also. They will not be able, they will not require any kind of an ERT procedure.
30% patient in our center carries a natural pregnancy. Those who underwent go for the multiple time IVF failures. And if the AMH is more than 0.5, 30% patient is carrying the natural pregnancy.
Yeah, exactly. So that is a basic advantage, I think, for these women. But how do you kind of manage these post-operative patients after this extensive surgery of peritonectomy and all that? Do you cover them up with any kind of medical management to prevent recurrence? Because recurrence is a big headache. Again, so we seriously don't know which are the women who are going to come back with the same problem in spite of doing such extensive disease, because as long as you have the hormones with them, they are going to have the disease. In such situations, how do you manage, sir?
We personally not believe in any hormonal remedy after the surgery. We believe still today gold standard is the surgery. If you clear the disease, the recurrence is very delayed. And in between, if the patient is carrying the pregnancy, this is the one of the right treatment for her. So also we not believe in any anti-adhesive agent. We tried we published our series related to 718 cases. In this particularly presentations, I think we used all the kind of anti-adhesive agent, Nutty, 4% dextrone, Interseed, and none of the drugs available in the market to prevent the adhesions. We believe that adhesion is individual matter, it depends upon the body tendency of the patients. Good microsurgical principle, good hemostasis play the good role to minimize the adhesions. But I think another one of the issue related to recurrence, if you do the incomplete surgery, I think the recurrence rate is much more high. And first surgery is very important part. If you do the post surgery perfectly, I think recurrence is very delayed. Sometimes it took the long time, but I think we realized that sooner or later on, endometriosis, there is some chances of the recurrence of this disease. In our institute, there is the lowest rate of the recurrence in the entire one. It's less than 1.8% in 5 years. Because our approach is different. We are more radical, we remove it. Why I started the bowel resections? Because in one case we operated 4 times, and every time we looked at, we remove the disease. Again, there is a presented with the involvement of the vagina, involvement of the parametrium and rectovaginal plate. In particular this case, I think we realized that also this one is the colorectal nodule and she is suffering from the severe dysphagia. and difficulty in the passing of the stool. So she is suffering lot related to constipations. And the first case we do many years back with the bowel resections, and this patient is even though enjoying the good quality life, and also it's improved the, she also carry the pregnancy, carry the pregnancy. So we started the aggressive work related to this bowel resections, but we realized that treatment should not be versus the disease.
Yeah.
Particularly in this era, I think we are more radical toward the bowel resections. And 2017 onward, we realized that. And now we are, after 2017, we are more toward the organ sparing surgery. Because we realized that this is the benign disease, is the localized one, majority time on the anterior surface of the colon. And if you do the saving or discoid and remove the disease, at least more than 95%. If you leave the sum of the part of the disease, recurrence is very less.
Yes.
It's less than 4%. But it gives the very good, wonderful quality of life of the patient. So I think rather than the radical approach, first you tried with the conservative approach. Is always
Very
because LAR syndrome is the worst than the disease. And I think we do the same mistake and we realize our mistake, and then we gradually switch over toward the organ sparing surgery.
Correct.
Even though in our center 10 patients scheme for the bowel resections and 10 patients for the ureteric implantation, among that only the one patient is required the ureteric implantations or bowel resections. We do the minimum 50 to 70 cases every monthly. Sometimes we cross more than 70 cases. So averagely we do the 700 cases plus of the redo surgery for endometriosis. Our center main is for the redo surgery for the endometriosis. Among the hardly we do the one bowel resections in the 1 month.
Right.
So we reduce the ratio and we realize that I think the organ sparing surgery conservative approach is much more better than the radical approach for the endometriosis.
Right.
Because we passed from the same pathway from the 2003 to the 2017 and again we came back and we realized our mistake. So I think our focus is more is conservative organ sparing surgery rather than the radical approach. So now.
That's a very, very important and take-home message for everyone, in fact, because people getting into so much of radicality with this endometriosis surgery, not realizing what is going to be the future outcome for these women. And because you have a very, very long history and you've been having so much of an experience, you're able to very clearly reiterate that it is only the conservative surgical approach which is going to help them and not the radical one. I think that point has to be really taken up, and then people should also start looking at it in that manner, so because we are seeing so much of radicality happening in endometriosis these days, which is absolutely, I think, not the right thing to do. And
I convey the message to the young people because young people have the excellent skill and everything. These people have the journeys compared what we have the ups and downs in entire our 3 decades. These people is I think reach up within the 5 years or 7 years. But these people have the experience of not more than 5 to 7 years. Right. Because we entirely spent the more than 2.5 decades behind to the disease.
Exactly.
And then we realized that. So I think even though these young people is sooner or later on maybe agree with me related to my thoughts,
they will realize.
Yes, but it needs some time, I think, because it's a self-recognized things, I think. And now what's happened actually, the media, YouTube, WhatsApp and everything. If you do the bowel resections, people is telling, I think this one is great part.
Yes.
In our era, I think if you do the radical hysterectomy or tubal microsurgery, it's a great part. I think it's one of the most prime things, particular for the advanced things in the endoscopic surgery. Nowadays, everybody is thought that I think if we go for the endometriosis surgery, go for the bowel resections, go for the ureteric implantations, this one looks like the better one. Yeah. But in our journey, I think it's a very, very tough time to even though showcase our skill and everything. I tell you the one story. Because there is a only way to, I think, present your work during the time of conferences, and conferences is also hardly 5 to 7 conferences per year. I tell you the one story. In 1994, I presented my work in Foxy. So this is the paper presentation of the primary trocar through the umbilicus. And this is at Calcutta. And Alokendu Chatterjee is the organizing chairperson for this event. And my session is chairing by Professor Ganguly, and its slot is given at 7:10 a.m. early morning. So what's happened actually, at that time I traveled by the Howrah Express from Ahmedabad to the Calcutta. Suddenly in Madhya Pradesh the bridge is broken. So rather than the 48 hours, it took the 58 hours, and I reached at late night at 1 o'clock. In early morning, I enter into this hall, and I realize that I am the only guy and only the Madam Ganguly. No co-chairperson, no other people is also remain inside.
Okay.
And Madam is very strict. I stuck with the time. This is Fox event. At the same time, I request to the Madam, Madam, there is no person in the hall. I can no way you presented your work. Okay, so this is the 8-week talk. I spent the 5 days. Again, same evening, I pick up the Howrah Express and come back to the Ahmedabad.
Okay.
So I spent the 5 days just only showcase my work in the front of the one guy.
Okay.
So this is the time, I think. So at that time, the monopoly with so many Mumbai people. So I think we started with the 8-minute presentation of the video clipping or 8-minute paper presentations, and gradually people is now related to us. So this is the very long journey related to compared to the right now. What's the time people have it? I think immediately if you perform the one surgery and put on the YouTube, everybody is knowing related to you.
True.
So this is the, I think, create the name is also the very tough task, and you get the space to enter into this system. It's also very tough task for us.
Yes, very true. Very rightly said, sir. So I think you all took the steps and came down. Now our current generation want to just take their split. So that is the only thing. But then they are very good as well. Surgical skills are phenomenally good. But then we need to assess and see like which exactly are the procedures which are going to benefit the patient, not just because we have the skill, we have to be radical for every patient, is what of course you are also conveying. So with your vast experience, have you encountered any kind of complication in this particular surgeries of be it anything, and how have you handled it?
I think I tell you, endometriosis is very complex surgery. You have to have the teamwork. Because one take home message.
Yeah, it's a multidisciplinary.
Suppose being a gynecologist, I perform the bowel resection, is fine. But any complication or legal issues happen, that at the time you prove yourself, you are the trained person related to bowel work, it's very difficult. So shaking hand with the cross fraternity is very important, and you create the good team with the Uro, GI and yourself. So I think in our center, this is the protocol. I think we create the team, and those who expert people related to this bowel work, and also not only the somebody is GI person and not aware related to endometriosis, not possible to he do the best for the, even though he is the great GI surgeon. Yeah. But you have to train for the particular this disease. This is very important. Right. So I think
mainly a colorectal surgery. Yes. They have to be.
Yes, and it's the long-term association unit. Somebody is understand your philosophy, and you create the long-term associations with this team. Yeah. This is because every day, even though you learn yourself.
Right. Okay. Yes, it's evolving.
Yes, this is not the one day game. I think every day from the cases to cases, even your team will be learn. Yourself also you love, and yourself you also try to make the stretch.
Right.
Okay.
Yes.
I think stretching of the particular related to your skill, it's required the fluid rhythm. Right. It's a gradual process. This is ongoing process. This is not on the one day game. Right. Yeah. So I think good shaking hand with the good cross fraternity, it's very key part, particular for the endometriosis surgery. It's the different kind of the complex disease.
Right. So any particular patient that you can think about where you feel that your surgery has really turned her life around?
I think in the beginning era, once we started related to saving discoid and bowel resections, we faced a lot of problem related to, we are scared and afraid related to fecal peritonitis. One is the bowel leak. So I think at that time we are very aggressive related to ileostomy. So any doubt we feel that immediately we put the ileostomy. Once we have the experience, then we realize that there is no need to the unnecessary ileostomy. So we try to make the reduce the ileostomy, and even though nowadays uh, up to the 5 centimeter from the anal verge or less than up to the 4 or 5, we go for the direct anastomosis without ileostomy. But very important part, you try to make the explain to the patient relatives and patient. If any leak, I think immediately we go for the stroma, redo laparoscopy and stroma. In our center, we have the documented audio visual recording. So I think we explain thoroughly, step by step. And even though we took the consent related to ileostomy in all cases, we also explained related to our faculty related to GI and Euro. And we also try to make the explain these people, this is not the single man soap. I personally believe that there is no medal particularly for the bravery in the medical field.
Yes.
Okay.
True.
So I think we explained thoroughly, and we took the audio visual consent for all the patient, and very light way we try to make the explain related to all the complications. It's maybe injury happen over this bladder, ureter or bowel. If happen, I think we take the such kind of the step. And also we try to make the told for there is just some chances of the 1% mortality in this, but with the large experience we realize that nothing will be happen. But in the light way, whatever we try to make the explain thoroughly. And in the beginning of our era, we faced the 3-4 cases because the fecal peritonitis. It's the worst part. The morbidity and mortality is so high.
True.
And immediately any doubt related to, I think you suspected the leak, negative laparoscopy is also plays a big role. Okay. Immediately if you feel that this is, even though you go for the CT contrast, rectal contrast, you not find out any leak, but if you feel that there is something wrong remaining inside, go for the negative laparoscopy in these cases. So this is very, only the one part of the ureter and bladder is very friendly, nothing will be happen. But I think fecal,
that will not spare
it's not take any lightly, otherwise आपकी नींद खराब कर देगी.
True, very true. But why do you think so? There's so much cases of DIE these days. In our practice itself, I think we are seeing at least on 10 to 20% of the daily OP itself, we are having DIE cases. Why do you think is so much of the...
I think we realized that after the COVID era, the incidence of the particular endometriosis will be increased, maybe due to the vaccine, maybe due to this virus. But I think it's very difficult to recognize in our institute because it's the tertiary care center for the endometriosis. And our 70% work till today is from the out of Gujarat. So it's very difficult to tell the incidence of the endometriosis. Maybe the diagnosis modality,
or
maybe
high degree of suspicion, and we are able to pick up much earlier.
But I think I am absolutely, Mala, agree with you related to after the COVID. I think the incidence of the endometriosis
has really gone up. No?
Yes.
So maybe the environmental pollution, so much of junk food going in, all those things, epigenetic factors are also playing a vital role. Also,
I think
I think after COVID only those eating habits also changed with our people. People now hardly like to cook and eat. So it's all the fast food which is also adding to the, I think, toxicity in our system and contributes to all these diseases.
But it's not proven, Mala.
Yeah, it is not proven. But then we have literatures also saying these epigenetic factors, environmental factors, all those things also playing a role also. Okay, so but because we are seeing even young girls these days, so it is really pathetic to see adolescent girls suffering with endometriosis.
I think I operated one case. She is only 9 years old, And recently I operated 6 years old girl
Yeah,
with the
because it
endometriosis.
arises in the fetal origin.
Yes.
But then, of course, once the hormones all get triggered, there is obviously there. But then when they're presenting it at a severe in the severe form. Like it is not just the mild endometriosis. That is what I have noticed. So
I
what do you
think
feel?
I realized that in the less than 14 or 15 years young girl, majority is the weight type of disease. Weight means it's easily separable adhesions, not penetrated much more. Majority with the chocolate cyst,
Yeah.
and whatever we told that it's the dry type of disease is the DI. DI majority cases we find out after the age of 50.
Right.
So I think this is the one of the advantage in the young girl with the endometriosis. It's just you lift up with the suction cannula automatically.
Provided they are not into any kind of a medical treatment
treatment.
prior to that, which will cause fibrosis.
And another one take-home message that we realize that Dinoges, Lopride, Tugolix, all are really nonsense drugs. It's create the lot of fibrosis and it's the loss of elasticity of the tissue, because we every day we do the work for the endometriosis, and majority patients took the Dinoges for the 2 years, even the patient took the 6 Lopride or 9 Loprides associated with the bone pain, the osteoporosis. So I think I realized that somebody is, I think, wants to prolong for the couple of months. At that time, you give the shorter time this medicines. Yes, but I think this is not this is work as a pressure. It just reduce the progress of the symptomatically patient is improved, but the disease is progress going inside.
So that is.
So I think it's not fair to every patient switch over on the medical line of treatment, because surgery is more difficult. Find out the plane of cleavage is also very difficult after medical management.
Yeah, they cause more fibrosis because these medicines do not act on the fibrous tissues also. So I think basically we had a very nice interaction to know about your entire journey and your passion for this particular field, and how you have really climbed up the ladder with so much of difficulty. So what would be your take-home message for our junior colleagues?
Particularly for the junior colleagues is have the obviously Mala, even though you observe that it's the better skill than us, because these people is very aggressive, all the material is in front of him or her. So I think the journey what we face the problem, these people have the very short journey. Skill for these people is much more better but more aggressive. So I think specifically I believe that endometriosis is the benign disease. It's behave like malignancy, but it's a benign disease. So you treat it as a benign disease. And organ sparing surgery, conservative approach, it's a big role, because treatment should not be worse than the disease. And such complications with the aggressiveness in the endometriosis, it's end up with the huge morbidity and mortality.
Right. Very true. So excellent take-home message. I think that is very, very important, because the disease is also, the incidence is going up, and our treatment should be tailor-made, and it has to be conservative and not too much of radicality in this particular thing is what you have been highlighting. So I think on behalf of IAG, I would like to...
Endometriosis still is the enigma. Certain reason we couldn't know that. But we know the certain fact. On the base we designed the surgery. Still is lot of research is going on related to center to the center. Suppose we favor toward the more related to conservative approach. Somebody have the experience of more related to radical approach. But you balance it. And it's a approach is different from the patient to the patient. And it's came with the experience. So I think try to make the understand related to the severity of the disease, accordingly that you plan of the design and proper mapping of this disease is very important before you start the surgery.
Yes, so the pre-operative evaluation is very vital, so that we'll be able to plan the surgery, and you'll also have the concerned team along with you to perform the procedure. It's very true. So thank you so much for your
Thank you, Mala.
valuable
Thank you, Mola.
time and spending your knowledge and also sharing your entire journey with us, sir. So on behalf of IAG, I thank you so much, sir.
Thank you, Mala.
Thank you so much, sir, for your time.